The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and thank you for attending this morning's webinar on the warm handoff process, considerations, and opportunities. Before we begin, I'd like to just review a few of the objectives that we will be covering today. Our first objective will be to understand what is the warm handoff process. We will take a look at what the role of the warm handoff is in the access to care, the role of the CRS persons with lived experience in the warm handoff, how it is being used now and opportunities for the future, and considerations for training and support for the workers, as well as looking into the future and where the warm handoff can lead. When we take a look at what the warm handoff is, as SAMHSA describes, warm handoff is an approach in which the primary care provider does a face-to-face introduction of patient to the behavioral health specialist to which he or she is being referred to. The role and function in the CRS and warm handoff process is in the access to care. The warm handoff assists in identification and access to care for persons with a substance use disorder. It can allow for access to peer recovery support services to support the recovery process, and can improve the retention in care. What we are seeing is that as individuals are being engaged with a CRS or any personnel within the warm handoff programs, we're having a significant rate of individuals interested in and getting into treatment as a result of that interaction. And the warm handoff process also provides support and education to loved ones and our larger service system. In this opportunity, we take the time to discuss with our loved ones who are present with their overdose survivor in the emergency department, as well as educating the medical staff on how to best care for an individual when they are coming into treatment for an overdose. We seem to be stuck on a slide here. Saving the lives of our loved ones, quote that I found to be very powerful from Gary Tennis Esquire, is that we must understand that if a drug overdose survivor is released back onto the street, their lives are in great jeopardy. When we see an individual in the emergency department or they are met with EMS, oftentimes they are brought back with the use of Narcan. And in previous attempts, they have often walked out with nothing more than a phone number or being asked to be told to get in contact with future services through one of the drug and alcohol providers for outpatient assessments. And when we are able to eliminate that gap and meet with an individual once they have been brought back into the emergency room and connect them with services and talk about where a CRS has been in that role previously and where they are in the beauty and positivity of recovery, oftentimes it helps in the engagement of that individual wanting to move forward with treatment. The warm handoff process is used to provide screenings, assessment, treatment, and tracking for persons with substance use disorders. A warm handoff can ensure that survivors of opiate overdoses receive an immediate handoff to the appropriate drug and alcohol service once they've been medically stabled. And one of the key roles within the warm handoff is to assure that the healthcare professionals can get help, can get people help while they are more deeply understanding the stigma and the intense shame that accompanies a substance use disorder. Oftentimes I've heard people when they have come into the emergency department from an overdose that they did not feel that they were treated as though any other disease that may have been come in. If we look at how we treat people with heart attacks or with a diabetic shock, oftentimes there's a greater care that goes into making sure that individual's stable and following up with the immediate care that needs to be taken care of for the individual to be successful in maintaining their health. And it is equally important that when we deal with individuals with a substance use disorder, that they're given that same level of respect and dignity. And the warm handoff process can be adapted for the use of other cares and social systems as well. We are seeing a greater increase in warm handoffs being used both in the criminal justice system as well as with children and youth and mental health systems. In recent research in Ohio for the mental health and addiction services, one of the claims came in that the department outlined in Ohio, the department outlined that they plan to invest $1.5 million in the year 2015 towards 17 projects serving 31 counties, which help link nonviolent offenders with community-based behavioral health services. The county jails are not the proper treatment facilities for individuals who have behavioral health issues. Providing linkages upon release from jail to community-based treatment, and it improves the likelihood of successful reentry and contributes to the welfare and safety of the communities at large. It's important that when we are working with the warm handoff process that we are making that genuine connection with the individual. Making the connection with a person in crisis is critically important to engage the process of change. Having the individual who has recently survived the overdose understanding that the person that they are talking to and the people involved in their process and their care team can understand where they're at and the importance and the fear that goes along with the possibility of change. It's important that we take the time to establish that relationship so that we can move forward with other aspects of the warm handoff. We don't want to face them with a mountain of paperwork. We want to establish that connection. Once that connection has been resolved and we have worked towards having a common understanding, we have a more significant rate at getting people to be invested in what our individuals in the warm handoff team are trying to engage. Persons who have lived experience with substance use recovery plan, they play an important role in this function in the process as an element of peer recovery support services. It's important that we are able to relate on a one-to-one basis with these individuals who have survived the overdose, for them to be able to see a person they can connect, who they know has been in their shoes. So engagement is one of the key elements in the warm handoff process. Our first impression with them does matter. What do we want to show them? We want to show the people we engage with that we start working with. Do we want to throw them a packet of paperwork and hand them a list of phone numbers? Or do we want to engage them with hope as individuals with unique strengths and resources that can be marshaled for change? An effective therapeutic relationship requires several things, but one of the three things that we want to focus on today is the spirit of collaboration. We want to have that emotional bond. We want agreements on what the tasks and goals at hand will be. And we want to meet the individual where they're at and understand what the expectations are for us in the role of the warm handoff worker, as well as the individual who has recently survived an overdose. So I'm curious at this point, I'd like to check in with those on the webinar and find out are warm handoffs being implemented within your community? And at this time, I'd like to open it up for questions. So if you have questions, if you wouldn't mind just typing them in the box, and we will get to each of the questions as they pop up. So are there any statements or questions in regards to the warm handoff and what's going on within your communities? Thank you, Manny. No questions at this time. How do you? Jennifer, could you elaborate on on your question a little bit further? The code, I'm sorry, to go back, Cindy, the code for calling in, this is, it should have been listed in the invitation that came out through email regarding different ways to access the webinar. Okay, let's see here. From Bobby, we have a big problem in finding detox beds for individuals who also have a medical comorbidity. I think finding detox beds in general across the state is challenging at this time due to the number of bed space that is available. If you would like to shoot me an email, Bobby, I'd be happy to kind of get into that issue with you a little bit further following the webinar. And in the chat box, I will put my email address for anyone who would like to follow up with questions with me following the webinar. Let's see. Next question that we have is Westmoreland County has been implementing this in the hospitals and having great success through the case management unit and the Drug and Alcohol Commission. I'd be interested to hear more on that. Was it Katrine Shaw? I'd be interested to hear that the success that is coming out of Westmoreland County with that. I do know that there are a number of counties that are reporting fairly good success rate when they are implementing the warm handoff in their areas. And the next question is from Shane. There's a warm handoff in place is that Williamsport Police, but it is apparently not happening as the police are not utilizing it. Again, Shane, if you would like to reach out to me after the webinar, that is something that we could discuss further. And if anyone on the webinar has any input that would like to offer to that question, again, the question is there's warm handoff in place in Williamsport Police, but it is apparently not happening as the police are not utilizing it. And the next question that we have is, how do we change or work the way our clients are treated in the emergency setting? It is a problem. Yes, I think everyone on the webinar would agree that it is important that we continue to educate our medical professionals as they are working with our overdose and our individuals who are struggling with addiction. I think the best way that we can go about and combat that issue is to continue to educate, continue to try to develop more of a rapport with the medical staff in the emergency departments and offer as much education as we can. Most physicians, from what I've spoken to back in the day, there was not that significant amount of training going into addiction science, and how we treat in individuals they come in with a substance use disorder or possibly an overdose. So I think there's ways that we collectively across the state could work to continue to educate not only the doctors but the medical staff as well in terms of addressing the stigma associated with addiction, as well as how we treat an individual when they come in. We certainly aren't going to turn away, as I mentioned earlier, we certainly aren't going to turn away and have a lack of regard for someone who may be suffering from a heart attack or a diabetic issues. So it is important that we continue to educate even our medical professionals and medical staff in terms of correct terminology and understanding the best effect for approaching our individuals as the person that they are, and not just seeing the disease. Let's see, from Barbara, yes, I just got my hospital involved in the warm handoff process. Excellent. Barbara, I'd be interested to hear what hospital that you're working with and getting some more feedback on that. So again, if you wouldn't mind shooting me an email afterwards and letting us know who we are, who you're working with in regards to the hospitals and what steps you've taken to fully engage the hospitals in your area to participate in the warm handoff process. I would appreciate that. Hello, Robin. Let's see. We are aware that CRS are working in the hospitals that have been hired by insurance companies, have no way of knowing actually how they're being handled. That's a question I'd like to have a little bit more discussion on regarding that, because there should be each hospital is going to manage their CRS differently, and if one is employed through the hospital, then I think they have a certain protocol for where that CRS role is. So if we are talking about a CRS that is working for an outside agency and moving them in, for strictly being called for an overdose survivor that they need to meet with, I think it's important to understand how the CRS is handled in each role, whether it be through the organization being called in or being actually employed in the hospital. So while I applaud the hospital for having the CRS on roll and on staff to address with the opiates, perhaps having an understanding of what it is like in each domain in which the CRS is working in. Hi, Neil. Yes, the RACE project does provide warm handoffs in York County. I know they have been doing that for quite some time, and again, I'd be interested to, there's a portion in our webinar in which I talk about what the role is in the CRS and the impact the role of the CRS has for the individual providing that service. So I would be open for input from you, Neil, during that port of time once we get into that segment. William, is there a system that will allow to view the available detox beds? Okay, so that gets more into the treatment provider side. I do know, depending on what treatment facilities are providing detox, they often have a list of who has beds available and where. In regards to having a detox list available, updated detox list available for those who are providing the CRS or warm handoff program within the hospitals when we are doing the bed searches. At this point, to my knowledge, I do not believe that there is a standard list. However, that is something that I can certainly look into and provide an answer back for you. So again, if you'd like to take my email down, I will be happy to see what I can do about finding you some information regarding that. Next question is from Amy. Are we using this and have the issues also of finding beds we have for treatment centers we call in the night? Could you rephrase that question, Amy? You're using the warm handoff, I'm assuming that's what you're referring to. And you also have the issue of finding beds for treatment centers when you call in the night. So finding available bed space if you have an overdose survivor that you're looking to get into treatment at, say, 4 o'clock in the morning, how do you find a bed available? Am I understanding that correct? And unfortunately, that's part of where the bed search comes into play. I do know that there are some initiatives that are trying to be put in play in which we're trying to have a list of these are the detox providers, these are the detox providers that have beds available, but because of the rollover with who's in and who's leaving, sometimes they are not always kept up to current data. I do know that calling a lot of the detox facilities around can give you an idea, but I also know that time is of the essence as well when you have an overdose survivor who you're trying to get into treatment. But these are all really good discussion topics regarding the detox availability. Let's see, Neil, we get about 1 call a day. That's approximate. Okay. Cat. Amy, yes, okay, you're in Berks County. So you guys, I believe I actually met with Berks County, and they have a nicely developed program within their system. I think where we look at this issue is the number of overdose survivors that we have versus the number of beds available. But again, that is a discussion I think we could have on many topics on that. Let's see, Michael, how can this program get started? Nothing in my area of Carbon, Luzerne. Carbon and Luzerne, correct me if I'm wrong, Michael, but isn't Carbon County part of Indiana as well? Isn't that the 3-county county authority? Armstrong, oh no, that's Clarion, I'm sorry. If you also, Michael, would please shoot me an email. I have some information that I could disseminate to you regarding how to go about initiating contact regarding the warm handoff process. And again, for those that it may have scrolled right past, my email address is again at the bottom. I will send it through in chat. So the sense that I'm getting from those that are currently on the call, there are some communities that are offering the warm handoff. I'm curious, for those that have the warm handoff currently going on in your area, how are you seeing it implemented? Yes, hi, Michael, hi. Yes, I also saw that Armstrong, Indiana Clarion is operating with the warm handoff. And I believe it was my understanding that you all have been able to get, I think it was at least 50% of individuals who had contact into treatment. Excellent, Kat. I'll be looking forward to that email. Another question from Michael, is anyone having experience with warm handoffs from EMTs? So this is where I'm interested in terms of how are the different warm handoffs being facilitated in your different counties. There are some counties I'm aware that once there is the overdose survivor, some are being called to meet the individual en route. Others are being called once the overdose survivor has been medically stabilized. So I'm curious as to how are they being implemented in different areas? So Allegheny Valley Hospital, Barb, has just started to implement. What's the success that you're starting to see with the individuals who are involved in the warm handoff through Allegheny Valley? And then from Heather, I have, I believe there should be more CRS that could go in the jails and be a support for them while the person in jail, Tioga County, there's only one service that is going to the Tioga County Prison, which is Harbor and not Crossroads. How can we change this? Again, the best way to change is to continue to educate and work together. Take a look at what the needs are within the communities and find a way to implement the programs and services, providing an outline of what the services can be put in place. Warm handoffs are being used, as I mentioned, not only in drug and alcohol, but we are starting to see across the board an increase in warm handoff procedures, both with mental health, in the criminal justice system, as well as children and youth. So this is something where people are starting to see the positivity of implementing that contact right from the gate. Heather, if you also would like to email me, I'd be happy to kind of, hear a little bit more about what is going on in your area and see if there's ways that I can provide some resources for you. Northampton County has drug court. We've made great strides in changing the attitude from lock them up to treatment. However, we have a ways to go. Any insight into how to bridge the legal concerns with treatment? That's a very good question, Tim. I think, as we all are aware, the more we can continue to educate and the more we can utilize treatment as opposed of jailing, we are going to see a higher success rate in the individuals. To me, it's holistic. We need to take a look at what is the root cause. Why are these why are people in certain situations that they're in? If they're drug related, how do we steer them in a way that is not something that is going to bring them right back into a recidivism rate? I think in regards to how do we change and how do we bridge the legal concern with treatment? Persistence. We have to educate the benefits on treatment versus jailing. We have to show the resources available, and we have to be able to show the positive outcome that comes with when an individual is receiving the appropriate treatment and services that that would benefit for their substance use. Barbara Penn, what is the liability for a volunteer going into the ER for a warm handoff? I'm not certain I understand your question, Barb. A CRS, are you speaking in regards to a certified recovery specialist, or are you speaking in regards to someone with lived experience going in to speak with an individual? There is a significant amount of training that goes into developing the CRS. And later on in the presentation, what we're going to see is what effective training, or excuse me, incorrect word, what we are going to see is training that is required for the certified recovery specialist, and then as well additional training that is required when the certified recovery specialist perhaps may be doing screenings or assessments. The essential role in the CRS is that you're able to establish that connection with an individual by sharing personal experiences, having a belief in the recovery system. And when we are sharing on personal experiences, it is not a responsibility that falls on the CRS that this person will go into treatment and not use again. I'm not sure if that answered your question or not, but that's what that's kind of the premise behind it. The next question is from Tammy. Education is key for medical personnel in regard to awareness, needs, and resources. Although emergency departments are aware of clients with addiction issues, they aren't making necessary referrals from the hospital setting. And they may be aware of addiction, and they may be aware of what the physical symptoms of addiction are, and that is where we in the warm handoff process continue to educate and be persistent in our education of what the referrals are. I do know that there are a few counties who, when implementing their warm handoff, have been able to develop a connection between the medical departments as well as the CRS to the medical professionals get the individual medically stable, and then the referral for services and treatment is then more taken on by the person that is working within the warm handoff process to ensure that they are getting into the correct level of care. So it's important to understand that while the physician may not necessarily, or the nurse, or whatever medical personnel you may be dealing with, may not fully understand the addiction as a whole, where we find ourselves is needing to not only educate the individual we're working with, but showing the medical personnel what resources are available and how a simple phone call to the warm handoff program can fill the gap between their need to medically stabilize them and get the individual into treatment. Let's see, Neil, for about 2 weeks we didn't get any calls. It was because of carfentanil. Well, carfentanil is certainly a big scare, as well as the fentanyl. There was just an article released on that. The unfortunate part about that is it's going to be difficult to bring an overdose survivor back once carfentanil or straight fentanyl has been introduced into the body because of the level of potency. Let's see. This is from Nancy. In Southwest, we have an issue with the medically assisted treatment aspect. Doctors are referring them for counseling, but how is it that we as drug and alcohol can collaborate with them better in terms of managing cases? And again, I go back to persistence, educating all pathways to recovery, understanding what the options are, and continuing to be persistent with what our program has to offer, and having resources readily available. I have learned through a few agencies that doctors aren't going to sit and read a multi-page packet. However, they will take a look at like a little business card that says we can help or something like that, and hand that and take a look at it and make that phone call. We need to be persistent. We need to continue to educate our medical personnel on the stigma associated with addiction and treating our individuals with dignity and respect. Let's see, Bobby, we have a case manager and CRS embedded in the hospital. That's fantastic. What county are you from again, Bobby? Is anyone seeing carfentanil? Carfentanil was something that was pretty prolific. We saw it in West Virginia. We saw it out in Ohio. But carfentanil is definitely starting to make its way through Pennsylvania as it's part of the route. So we do need to be extremely careful when we are also educating those that we know are afflicted and using the opiates, because they do not know what it's going to be cut with. But carfentanil is incredibly toxic. It's a large mammal narcotic, so it's going to make it a darn near difficult, for lack of a better word, to bring those individuals back if they've been introduced with carfentanil. Hi, Mark. Lancaster County, PA is in the process of developing and implementing a warm handoff process. Biggest hurdle identified so far is a lack of referral options, detox beds, MAT openings, and treatment options. I don't know that that's just in Lancaster County. I think everybody would argue that that's probably one of the #1 things is lack of treatment beds available. However, there are ways that we can work with the individual to help them maintain and understand the need for treatment and sobriety and their recovery by sharing our own personal experiences and motivating and implementing some of the techniques that we have learned through our CRS training. Let's see. This also is from William. Is it difficult because the medical staff in many hospitals do not believe that those that suffer from opioid detox is necessary to remain in the hospital, but release the individual when Narcan was implemented? Alcoholism and benzos appear to have precedence. Medical professionals need education that persons that just OD'd are an increased risk for OD or death. Many hospitals released opioid patients post-OD. Most of the individuals are in a state of crisis and many need time to process and contemplate treatment. Yes, and again, that is where the warm handoff comes into play. Here we are introducing individuals that are able to talk with an individual on a real basis about where their life had been, share personal experiences, and try to get that individual to understand their need for additional treatment. So not only are we looking to educate the medical professionals, the warm handoff is there to work with, educate, collaborate with the individuals and their families for the need to get that individual into treatment. Okay, we're going to take a couple more questions here, and then I do want to move on in the webinar. Allegheny Health Network is one of the centers of excellence for this year. I'm trying to find out how this works with the warm handoff. Barbara, please shoot me an email after this, and I'll be happy to get into that with you and have that discussion with you following. Again, my email address is in the bottom in the chat box. So again, please, and if there are any questions, I do apologize. I do want to get through the remainder of our webinar, so if there are any questions that I have not been able to get to, please, please, please shoot me an email, and I'll be happy to go through each of those with you following the webinar. We'll take one more here from William. What do we do as a CRS when the healthcare professional decides that they don't want to treat the survivor with respect? I have seen clients sent home from the hospital when they clearly need to be held at the hospital, mental health, or after an overdose. And that is where, as the CRS, you are their advocate. You understand what the needs are. It's not to say that medical staff will take what you have to say in absolute consideration, but it is your job to advocate for the individual and have that individual show that they have made the decision that they want treatment. If there's supervisors in place, contact the supervisors. Follow your chain of command in that. But we can't make someone decide to start treating someone with respect, but what we can do is correct their terminology with the appropriate terminology and make them aware when there are derogatory statements made about the individual that you know, it's inappropriate. Let's correct their language. Let's be the advocate for the individual who may be confused, who may have not made the decision that they want to change, who has the family that is beside themselves on the side. Let's be that advocate. That is our role, to be the advocate for that individual, to help make sure that they are receiving exactly what they need when they're in the hospital. I want to thank you all for your questions. They've been some excellent questions, and I apologize we don't have the time in today's webinar to actually go through all of them. But again, I'm going to post my email, and it is at the end of the webinar as well, for any feedback or any questions that you have that we did not get to. Please send me an email, and I will be more than happy to have a discussion with you regarding some of the issues or concerns or questions that have been brought up today. And once again, there is my email. And at this point, I appreciate all of the check-ins. That was wonderful. What I would like to do now is continue to move on to the rest of the webinar at this point, so that we can cover some of the other topics in terms of what the CRS's role is within the warm handoff. And the CRS, which is considered, for those that may not be familiar with the acronym CRS, but CRS stands for the Certified Recovery Specialist. The CRS have basic training and can have an important role in assisting in drug and alcohol care engagement on a peer-to-peer basis. So that's where you're able to sit down and speak with the individual as someone who's been in their shoes and relate and develop that connection with them, to hopefully motivate them to make that decision to move into the next form of care. And the role of the CRS in the warm handoff is the functions of the CRS in a warm handoff. They can include, but they are not limited to, providing peer-to-peer recovery support services to those considering or seeking assistance with a substance use disorder. They're there to develop rapport with the person served by sharing common experiences and hope. They engage individuals to transition into into drug and alcohol services, and they provide education to the individuals, the medical professionals, and their family and their friends. And I apologize, I don't understand why this is not going away. The CRS and the warm handoff, they're also intended to identify appropriate resources and connect to support and service linkages. They assist an individual in navigating the drug and alcohol care system. They assist in developing individual recovery plans. And they identify multiple pathways of recovery to the individual. And that is important because sometimes what I have dealt with in the past is an individual thinks that there's only one way to recovery, and when they are educated on the many different pathways that they can attain recovery, it opens the door for them. They also assist in identifying what that individual's personal strengths and needs might be to help further feed the need to follow through with drug and alcohol services. And as well, they also provide administrative and ancillary duties. So there are the very minimal paperwork that is required when you're first meeting with an individual in the emergency setting. But it's a demanding role. You know, CRSs are entering into a very highly charged environment. They're going to be negotiating with multiple systems and multiple entities. They're going to be managing back and forth multiple roles as they engage with the family, friends, and the individual, and then finding resources and medical and drug and alcohol service professionals. So you'll constantly be shifting back and forth, putting on your cap to deal with the families and providing that empathy and care and support to the loved ones, as well as to the individual. And then providing more of the advocate hat when you are dealing with the medical professionals. And then putting on your broker hat to address with the drug and alcohol service professionals. So there are a lot of different caps that are worn by the CRS when they are entering into that role of the warm handoff within the hospital. Another thing that we've learned too is that when the CRS was, the warm handoff was initially implemented, it was kind of designated as a position that might be best served within the emergency room setting for opiate overdose survivors. And through the last year, what we have kind of noticed is that those services can also be implemented in other areas of the hospital, whether it be the geriatric ward or the orthopedic ward or labor and delivery and maternity ward. There are a multitude of different areas within the hospital which a person may be identified as someone that may have a substance use disorder. So there are additional trainings and resources which should be considered when setting up and providing these services. Additional trainings and considerations is that training in systems and policies that they'll be working with. An example might be if you're working within the hospitals or within the prisons. It is important to understand what some of the different policies and procedures are within the hospitals or within the prisons so that you are able to flow and function better in your position by understanding what can or cannot, or excuse me, what is or is not permitted in the facility in which you're working. And then training and working in the medical care systems and how to navigate within these systems. It's important to understand the hierarchical of power when working within the hospitals. Oftentimes we don't get to go directly to the doctor or the charge nurse. We are essentially at the bottom of the care team members and have to figure out our way and negotiate our way to get to the individual that we need to speak with. So if we need to speak with the doctor, what are the channels in which we go to in order to attain the person that we are looking for? And then coordinating care for persons and family members depending on the setting and the role of the position. So we want to coordinate the care as best we can. If we're working with an individual in a hospital setting, What do we look for? Are they in need of inpatient treatment or detox? Working with possibly the social worker or case manager of the warm handoff team, working to find bed space availability. If that person may be homeless, what are resources that we can provide that individual to meet their needs until we're able to get them into treatment? Providing them with lists of different meeting lists in the area, whether it be for AA or NA or Narcotics Anonymous or Al-Anon, as well as providing support for families and giving them a venue for which they can go to begin to understand, giving them information on overdose survivors or opiate overdoses, and connecting them with local community and county resources. Some additional training is that it does require that all CRSs providing case management, providing assessments for publicly funded clients, complete all required and applicable DDAP approved case management core trainings within the first 365 days of hire. For any additional information regarding these trainings, that can be attained by going through their DDAP website and visiting the website, which is located at the bottom. And for those on here, https://appps.ddap.gov/TMS/. And that will also give you an indication of what some of the other training areas might be. Just to give a brief example of some of the additional trainings that would be required in order for a CRS to be able to provide case management and assessment for publicly funded clients, it would be a total of 36 training hours for assessment, from Addictions 101, confidentiality, practical applications of confidentiality laws and regulations, case management overview, screening and assessment, the Pennsylvania client criteria, placement criteria, practical applications of the Pennsylvania client placement criteria. And then there's also, if you already have those core trainings, then they are available for a continuation of care training as well. But those are just a couple of the indications of trainings that would be required for the CRS to be able to provide assessment for publicly funded clients. And we also want to consider that this is an incredibly rewarding job. But we also need to understand that what we're exposing our peer workers to is there's the possibility that a CRS could develop compassion fatigue or burnout, vicarious trauma, or even personal triggers that are related to their own recovery. Persons providing the services and are playing a key role. And we need to be mindful of how we train, support, and utilize workers in warm handoff settings. And this includes having quality peer supervision, proper trainings, statewide support for building out these services, and self-care for the persons who are providing them. Just a few tips on how to provide self-care for yourself. I know this was something I struggled with in the very beginning, but I think we all find our balance from time to time. But you want to take the time to offer some meditation and relaxation techniques. Allow time for yourself. Be involved in some physical activity. Some people like to read, escape from the reality of reading. They're taking themselves out of the real life and putting themselves into a fantasy world. Keeping our friendships, Having friends who are willing to listen and support one through good and bad times is so key. Of course, we have to have humor. Adding humor to a stressful situation can always help lighten the mood. We need hobbies, whether it's listening to music, drawing, playing sports, going for a run, playing in the garden. These are all great ways that we want to relax. Our spirituality is important as well. Actively believing in a higher power or divine being can have many, many, many great health benefits. If you're a pet person, have a pet. Take care of a pet. It helps distract the mind from stressful thoughts. Sleeping. We always want to make sure we sleep. I struggle with this, but for some reason it always comes around when I need it. Sleeping. The human body needs a chance to rest and repair itself after a long and stressful day. So make sure that you're allowing yourself the time to have the sleep that your body needs to recuperate. And make sure that we're eating right. Proper nutrition, it greatly improves your physical health as well as your mental health. Some of the micro elements are regarding the individual elements to consider for warm handoff helpers, and they're factors at the level of the helper. Take self-care for any existing trauma. We're asking individuals in a CRS role to go into an emergency room, and they may be faced with situations that can be emotionally charged, and they may trigger something for themselves that if they lack or do not pay attention to the need to maintain their self-care could be detrimental. Level of emotional and professional maturity. You always want to continue to work on yourself and take each experience and learn how to grow from each experience. The strengths of support systems. It is vital that we maintain a healthy support system and we have people in place that are there for us when we just need either to vent or unwind or laugh. It's important that we have a strong support system to help us with that. We need to maintain and find a healthy work and life balance, as well as maintain, as we mentioned, a positive spirituality. We need to have a positive connection to our higher power or something greater than us that gives our perspective. We also need to have a high level of self-awareness so that we can know when we are getting to the precipice of burnout or compassion fatigue so that we can retreat and take the time that we need to recharge our batteries. So the Mezzo element consideration, move that. It's the factors at the level of the peer, the group, family, or staff agency. It's an active social support from supervisors, colleagues, and family members. Using the buddy system, especially for novices or beginners in the field, having that buddy system on someone that you can rely on to be that sounding board and help support you through those stressful, difficult times. Use a debriefing. After a situation, take that time and talk about the event that occurred, talk about the way things played out, talk about the positive, talk about the negative, talk about the frustration, but debrief yourself from the stress that came from being in that emotionally charged environment. Development of informal opportunities to connect and participate in training opportunities. The more we can train, the more opportunities we have to grow and expand as a professional and learn new techniques that may be vital in handling different situations as we move through our field. Use the use of peer supervision or consultation teams. I always called them staffing. Have your peers around you to be able to talk about specific cases that may be difficult or that left you feeling some kind of way, falling back into the debriefing, and opening it up so that maybe we are able to see a more effective or beneficial way to resolve a situation or de-escalate a situation in a technique that we may not have thought of previously. And if it's indicated, participate in time-limited group therapy or individual psychotherapy. This can be on a formal or informal, but for individuals who are in their personal recovery, it's always a good idea to maintain your maintenance check-ins, just so that you can ensure that you are still on the right track with your own recovery. Excuse me, I'm losing my voice. The care and nurturing at the Mezzo level, this is where we utilize our colleagues, our families, our peer communities. And we focus on safety of each other and of the person that we're serving. We need to have an openness and inclusion in how we develop, provide, and train those in direct warm handoff services. Peer support and how we support and nurture each other. Collaboration and mutuality have peer supports for worker improves the outcome and protects against burnout. Empowerment, voice, and choice, honoring each other's experiences and perspectives across the delivery system. That is key. Understanding that a person is empowered in their position and that they have a voice and they have a choice is a wonderful way in order to engage what's the word I'm looking for, engage individuals to continue to have that passion regarding the work that they are doing day in and day out. And then cultural, historical, and gender issues. The power of honoring diversity of our fellow healers, and we bring that to the table collectively. Understand that the cultural and historical and gender issue plays no part in whether or not someone is going to be good at the role of helping others. They may be able to connect in ways that we are not, and it's important to use that collaboration and use it collectively. So when we look into the future, we see peer workers that they're an integral role, or excuse me, an integral element in the development and provision of warm handoff services. With the mindful development and training for these workers, they'll be fundamental to our larger service system force for many decades to come. And there are many opportunities to expand the warm handoff process to other service systems. As previously mentioned, not just the criminal justice system, but with mental health, as well as with children and youth. I think the possibility is endless in regards to how we could implement the warm handoff and ensuring that people's needs are being met at the time they are delivering and presenting. So what do you think? What are the thoughts on the warm handoff and what we've discussed today? And I do know that we are out of time, so if you all need to exit, I understand. But again, if there are any questions that anybody has, please feel free to shoot me an email. We are interested in feedback, so this is my final slide, and I heart this because that's just cute. We want a happy moment, you know. Please feel free to provide any feedback you have whatsoever. For those of you that had questions that we were not able to get to during the open part, I do apologize. But again, my name is Stephanie, and my email is provided at the bottom of this slide. Please do feel free to reach out with any feedback you may have, any questions you may have. And again, I thank you all very much for participating in today's webinar. I look forward to hearing from each of you. No question. Thank you, Manny. Let's see. Mercer County Coalition for Drug Awareness is planning to host a CRS course locally to develop a pool of trained individuals to use in worm handoff process in a variety of ways within the community. Much interest within our recovery community to become involved. What is liability of a volunteer?